Welcome to the Independent Sage Friday briefing. So this is where we're at now in the UK. More than 36 million coronavirus vaccines have been administered, and more than 5 people in the country have now had their second dose of the vaccine. With a couple of bumps along the road, the vaccination programme is now well and truly underway. However, some alarm bells have rung over the safety of the AstraZeneca vaccine, and some European countries like Germany are now advising people under 60 against having that particular vaccine. Our own government is insisting on the safety of the AstraZeneca vaccine and continuing to advise people to take it. We will be focusing on issues around vaccines as we take your questions today and hopefully clear up any confusion. The whole point of these briefings is to provide open access to scientific expertise and create dialogue between scientists and the public. But before we launch into that dialogue, Professor Christina Pargle has a monologue to deliver, and she gives us a roundup of the latest facts and figures. Christina, over to you.
Right. So, hi everybody. So just to say that we're going to be kind of experimenting with a bit of a new format for the briefing. So these data presentations will be every 2 weeks from now on. And then in the weeks off, we'll be having special guests and kind of diving into specific issues to try and really put a focus on them. So for instance, next week, we're going to be looking at global vaccination. And so because of that, because it's been 2 weeks since the last one and 2 weeks till the next one, this is a bit longer because there's a lot to cover. So that said, let's start. So the headline is really things are continuing to get better, but there is a clear north-south difference in England now in terms of case rates. So I'm going to go through cases, hospitalizations and deaths, vaccinations, and then a little look at what happened with schools when we opened in March, and then just something on the mass testing, which the government is planning from now on. So cases, so before I show you case numbers, I'm just going to show you testing numbers. This is England, where we can get tests by type. So LFD is lateral flow device tests, which are the kind of rapid tests that take 40 minutes to get a result. And PCR is kind of the standard way of testing, which takes a day or more to get results back. So you can see that when schools were open in March, there was a massive increase in these lateral flow device tests. That has dropped off over Easter, so that's going to affect the case numbers that we see. And we can also see in terms of the PCR tests that there was a big drop over the Easter weekend, expected, but again, that's going to change the case numbers. So that said, these are UK confirmed cases by reported date. And you can see they flattened off a lot over March, but more recently they have come down. I think some of that is because of less testing, and some of that is genuinely because cases are still coming down, particularly now schools are on holiday again. Looking at the positivity rate, so the proportion of people tested who are positive, this is only PCR tests. And it kind of takes account of changes in number of tests done. All the nations are now well below 5% positivity. That's really good news, and they're all declining. The ONS infection survey, which was released today, now looks at incidence rates, which is new infections. And again, the ONS infection survey is really good because it doesn't depend on people coming forward for testing. It just tests a random subsample of the population. And what they're reporting is that to the 3rd of April, new cases in England were going up. You can see that here. I mean, not very much, but a little bit. Flat or reducing in Wales, pretty flat in Northern Ireland, although much less confidence in the estimates there, and going down in Scotland. In terms of the kind of overall picture of where we are with the ONS infection survey, which has now been running for almost a year, we're kind of back where we were mid-September 2020. So it was a lot better than where we were in January, but that's still almost 10 times higher than where we were at our lowest, which was early July last year. Regionally, there is quite a big difference. So this is from the Imperial React study, which tests about 100,000 random people in England every month. They just released their latest results for March this week. So grey is where we were in February and orange is where we were in March. And you can see all the regions in the UK had quite substantial drops, particularly London. But what you can also see, if you just concentrate on the orange bars, is that the northern regions now have the highest rates across England, in fact, about double the rates of the southern regions in England. And if we look at case rates by deprivation, this is at local authority level, what you can see is that the most deprived regions have almost 3 times as many cases per population as the least deprived areas. And what that means is that now that we're coming out of lockdown, it means that more deprived areas are at much greater risks of having outbreaks and are in a much more precarious position. And that is kind of where we were last summer, and we saw that they ended up with kind of regional lockdowns, particularly in the Midlands and the North. And I'm a bit worried that we're risking that again as we come out now in this quite uneven situation. Looking at hospitalizations and deaths. So the number of people in hospital has continued to drop really, really steeply. That's really good news. We're now pretty much where we were at the end of May, early June last year. So that's also good news and kind of where we were in a similar stage of unlocking. If you look at it just by English regions, although everywhere is coming down, you do see the pattern that we saw in cases happen here too, that Yorkshire, the North East and the North West have higher hospital admission rates than London, the East and the South. So the kind of higher number of cases in the North is translating to more people needing hospital. So it is kind of a difference that we should care about. And here is some really good news on hospitalizations. This is from Public Health England surveillance data, looking at hospitalizations by age group in England up to the 28th of March. And you can see that for almost all of the second wave, the highest numbers of admissions were in the over 65-year-old groups, these 3 lines here. The vaccination rollout began here in mid-December. And what you can see is that for the first time at the end of February, the rates of hospitalizations in over 65s have now come lower than in the under 50s who haven't been vaccinated yet. So this, I think, is showing a pretty clear and unambiguous impact of our vaccination campaign, and that's really positive. In terms of deaths, we're continuing to have fewer deaths week on week. That's really good news. There were 800 in the week ending 26th of March, so more than 10 times lower than it was at the peak in January. And again, this has to be really welcome news. The REACT study also looked at deaths. And what they did is they looked at their case rates, which is this black line. This is kind of, you can see every 4 weeks they do their survey. And then they kind of overlaid on actual deaths that the government records, kind of lagged to match the infection. So there's a kind of, 4-week time difference between getting infected and dying. And you can see there's a pretty close match. And then what they're showing is that in the most recent couple of months, this red line is dropping much faster than the black line. And that gap is showing that you're having fewer people dying than you would expect. And that also is likely to be the impact of our vaccination campaign. So it is, there's no doubt that we are saving many, many thousands of lives through our vaccination campaign. So looking at that, these are vaccinations to 7th of April. Blue is the first dose, orange is the second dose. You can see, as we were warned, that vaccination is slowing down. 1.6 million people received a jab in the week to 7th of April, and we were kind of reaching 2.5 to 3 million, and even more than that in March. Some of that is Easter. So this is the Easter weekend here. We're also seeing that now we're shifting to mostly second doses. And the SAGE modelling subgroup released a paper on their scenarios for the next few months, and that included estimates from the government where they thought we'd be at 2.7 million doses a week till the end of July. And what that means is that really we should expect April and all of May to be mainly second doses, as we have to give second doses to all of these people who got their first dose in February and March. But that still means that there will be some first doses going on. And so we should still be able to give all over 40s the first jab by the end of May, and then quite rapidly then vaccinate people in their 30s and 20s, hopefully by the end of July. So the proportion of all adults given at least one dose is now 60%. You'll start seeing this flatten off now as we're doing mainly second doses. And we're seeing second doses, so fully vaccinated adults, really shooting up. Wales in particular is storming ahead here. And the other nations, all about 11% of adults are now fully vaccinated. This is really good. And we can see it here by age. So we're now getting to almost 60% of the over 80s have had their second dose. So again, this is really good news. These younger age groups getting a second dose are people who would have been in the higher priority categories, either health and care workers or people who are extremely vulnerable or shielding. Now, one thing that we want to be watching out for as this carries on over the next few months is how close we can get to the first dose percentage. So are people coming back for their second dose? Because that will be really important to track, and particularly as we move into younger age groups, where we might expect to see fewer people engaging with the vaccine program. So that's something that I'm going to be watching out for. If we just look at it by deprivation, this is first dose coverage by deprivation for everyone over 55 to the 1st of April. And you can see that although uptake is high everywhere, there's still a 10-point difference between the most deprived and least deprived communities. And this is something that we do really want to keep addressing, because it does still leave a lot of people potentially vulnerable to COVID. And if we look at it by ethnicity, it's even more stark, where 93% of people over 55 who are white have had their first dose, compared to only 65% of people who are Black in England. And what this does mean is that there will be some communities now who still have a lot of vulnerability to COVID as we open up. Now, the good news is that a new survey from Ipsos Mori showed that attitudes have changed among ethnic minority Britons over the last 2 months. So in January, 22% of people in ethnic minorities said that they definitely wouldn't take the vaccine. And now that's moved to only 6%. And 50% say they definitely or probably would take it. And so there is an opportunity here where we can actually say, you know what, it's not okay that we have these big gaps by ethnicity, and really work with local communities to make it very easy to get the vaccine and to address concerns, particularly now with the latest news about AstraZeneca. Just moving on to schools. So for the first time last week, when the ONS released its infection survey, they also released detailed modelling of the number of cases by every year of age, and they did it for each of the 4 nations. Previously, we only had age data for England, so now we have it for England, Scotland, Wales, and Northern Ireland. So I thought we'd look at Scotland, who opened schools the earliest in the nations. They opened primary schools on 22nd of February. So this is a modelled age distribution, which is why it looks so smooth, of COVID in Scotland from the ONS infection survey. This is a proportion of that age group with COVID in percent. So this is 1%. So it's all quite small numbers. And this is the estimates on the 20th of February. And this is year of age. So this is the youngest people up to the over 80s. And in mid-February is, mainly between 25 and 40 with the highest rates. And then primary schools opened on the 22nd of February. So if we skip forward to the 6th of March and their estimates for the 6th of March, what you can see is that although the rates have decreased in the older age groups, we're now seeing more cases in children or people under the age of 22. If we skip forward again to the 20th of March, it gets even more dramatic. So cases in the over 40s are continuing to fall, but cases in school-age children are continuing to go up. Now, these are models, but they're based on random survey testing, so they don't rely on people having symptoms. And that's the really big strength of the ONS infection survey, because we know that children are less likely to get the classical symptoms of COVID, and so get a test that way. Now, if we go back to the ONS infection survey today, they're showing that the incident rate in Scotland is dropping. So it could be that the decreases in the older age groups more than offsets the increases in children. And the other thing to note is that if you look at the actual confirmed cases through testing in Scotland by age, this is from data up to yesterday, you can see that although cases definitely went up quite a bit in 0 to 14-year-olds, they did then seem to flatten off towards the end of March and have now decreased, unsurprisingly, over the Easter holiday, and we should keep decreasing until schools go back. But it is something that we really want to kind of watch out for what happens when all schools go back full-time in Scotland next term, and also in the other 4 nations. In England, the ONS effective survey from today shows these kind of age ranges, and it's not that clear. So they were saying you can definitely see a small increase in secondary school children and school year 12, which is, I think, 16 and above to age 24. But you can kind of see that it kind of goes up a bit and then comes down a bit. And again, school holidays started probably around here. And the REACT study, which released this week, also had an age breakdown. You can't really track the time course because it was done in February and then in March. But now you can see that the highest prevalence of COVID is in children aged 5 to 12 in England. And this was the last 2 weeks of March. And then the kind of final section is just on mass testing. So this is because the government announced that tests are to be offered twice weekly to everybody in England. So this is lateral flow device tests, the tests that take 30 to 40 minutes to do. And so these are kind of the charts we'll see. So what we'll see, if it works, is that these numbers are going to get very, very much higher. So instead of doing 2.5 million a day, you might see 10 times that. So the other thing that they're saying now is that all positive tests from a lateral flow device will be subject to PCR testing. Now, that's really good news. What it will do is it will reduce the chance of someone having a false positive, so testing positive when they do not have COVID. And it also helps the government track any new variants that they're worried about in England, which is a really, really important thing to do. But it will affect case numbers, so it will reduce the number of positives. Again, that's a good thing because you're reducing false positives. But it just means that the numbers won't be directly comparable going forward to now. So the plan is that all adults are going to be encouraged to do twice weekly lateral flow device tests at home. I mean, school children already have lateral flow device tests, but it has a lot of problems. So as far as I can tell, the government isn't adding any more support for isolation. People who are eligible can still apply for the £500, but that's only 1 in 8 working adults, and only 30% of those actually get the money. So you have really no incentive to test if you're not able to isolate on a positive result. And so the whole policy won't work if we're not actually allowing people to do the thing that stops infection, which is staying at home and not infecting other people. The other thing about lateral flow device tests is they're quite unpleasant to do. So I don't know how many people have done them. I've done them. They're unpleasant. They make you gag. They're difficult to do properly because you actually have to get pretty far down your throat and up your nose. And so really, if you feel totally fine and you have things you have to do in your life, there's very little incentive to test. And so what worries me, instead of everybody doing it, you risk people only doing it if they're particularly motivated to do it, or if they have some niggling symptoms and they think, oh, I'll just do a quick LFD test. And if you have symptoms, you're meant to go for a PCR test because it's that much more sensitive. The latest government estimates is that they're 94% sensitive compared to lateral flow device tests, which is somewhere between 50 and 70% sensitive. So what that means is you really want to have PCR to catch people. If people are relying on lateral flow device tests, if they're symptomatic, you will miss cases and allow COVID to spread. So that's really worrying. There are about 44 million adults in England, right? So even if most people don't do it, you might still get 20 million tests twice a week in people who do not have COVID. And of those 20 million, about somewhere between 6,000 and 20,000 people will test positive, and that will be a false positive. And that's using the government's own estimates of how accurate those tests are. And they are very accurate in terms of not giving you a false positive. But if you're testing so many people, that's a problem. What the government is saying is that as soon as you test positive with a lateral flow device test, contact tracing will be triggered. And it stops after you then get a PCR test that tests negative, and you have to get that within 2 days. And they're saying that as soon as your lateral flow device test is positive, you have to isolate, as does everybody you live with, right? So if you have kids, they can't go to school. If you or your partner have to work, you can't do that. And you have to wait for your PCR test to release you. So if people use this as intended, that means that potentially 6,000 to 20,000 people each time they do a test, each time you get these tests, might have to then isolate for 1 to 4 days for a false positive while they wait. Now, the question is, at the moment, there's no sign that these people will have financial compensation or any support for disrupted plans, so kids missing schools, care and responsibilities. And I just think that unless there's something done to support people for that period of time, people are not going to participate in this testing program. And just one last slide, just saying it's not over yet. Things in the UK seem, to be honest, pretty good right now. We do have much lower cases than we did, but in terms of the overall picture, the world is experiencing another major COVID surge. And this is particularly relevant as we're having in the news today about foreign holidays after May. So just to summarize, cases, hospitalizations and deaths are flat or falling in all nations. But as we emerge from lockdown, the most deprived areas have case rates almost 3 times higher than the least deprived areas. And that means that they're in a much more precarious position as we open up. And they also have lower vaccination rates. So vaccination is going really well. We should expect mainly second doses until the end of May. But we do still have disparities by deprivation and ethnicity, and we should address those. There was a rise in cases in school-aged children after schools reopened. It's likely that these will reduce quite substantially over the Easter holidays, but we do have to keep track of what happens when schools go back in a week or 2. And just the government's mass testing initiative does have a lot of problems. And as the government announces plans for foreign holidays, the world is experiencing another COVID surge. And I will leave it there.
Thank you very much indeed, Christina, for that very comprehensive summary of the latest facts and figures. And we're now going to take some questions from the press and public. And first up, we are going to Nigel Nelson from the Sunday People. Nigel, what's your question for us today?
Hi, Alice. It's the safety of the AstraZeneca vaccine. It appears to have been determined purely on the basis of statistics. So any age group can get blood clots, and the only reason under 30s have been told not to have the AZ vaccine is they're less likely to die from COVID, and therefore the risk is greater statistically of getting a blood clot. Has the safety of any other vaccine ever been evaluated in this kind of way?
Thank you very much, Nigel. Who'd like to start with that? Dr. Kit Yates.
So I can't speak about whether the safety of other vaccines have been evaluated in exactly the same way. Certainly, the COVID vaccines that are just coming on stream now have not been given to as many people. So AZ, in terms of real world, is the biggest sort of real world experiment that we have at the moment. But in terms of the relative risk, so the risk, we should say, is extremely low. There is a gradient of risk with age, and there's also a gradient of benefit from getting the vaccine with age, because younger people are less likely to have severe complications when they get COVID. So there was infographic that came from the Winton Centre for Risk, which is headed by David Spiegelhalter, and it was put together by Alex Freeman, which looked at the potential benefits of getting the vaccine. So by benefits, they talked about number of people being kept out of the ICU because of COVID versus the potential harms due to blood clots of the vaccines. And they looked at the numbers of people who might be expected to go into the ICU versus the number of people that might be expected to go into the ICU either through COVID or through getting one of these blood clots, and they effectively found that with incidence rates at the rate they are at the moment, around 2 per 10,000 people, the trade-off for all age groups is that it's better to get the vaccine, apart from potentially for between 20 to 30-year-olds, where marginally the benefits of getting the vaccine are slightly outweighed by the potential harms, which is why that it's been suggested that age group receive this alternative vaccine. But I think what we should stress is that the risks are extremely low from getting the vaccine at all. But in that age group, it maybe makes sense if we've got the vaccines available to give these age cohorts a different vaccine.
Thanks very much, Kit. And have we seen this with other vaccines, this kind of fine-grained approach to the risk at different ages? Do we see that? I wonder if, Deanan, do you have any idea about that? Because Nigel was asking about the comparison with other vaccines.
Yeah. Yes, Gabriel had his hand up and may want to address that.
Okay. Professor Gabriel Scally.
Yes, I just want to say I wasn't quite sure whether, wasn't it, Nigel, whether your characterization of the risk was entirely correct. There is quite a steep gradient in terms of risk with age. So according to the image that was produced at the briefing, the risk per 100,000 people of a serious potential harm varied from 1.1 per 100,000 for the 20 to 29-year-old group, down to 0.2% for the 60 to 69-year-olds. So that's more than a 5-fold difference. So there is a clear gradient. And then when you add to that the risk, when you look at the risk, however, of COVID, which goes in the opposite direction, and people who are older are much more likely to die with COVID by a huge extent, more than those from 2029. It is very clear that the 20 to 29 group, it would be wise for them to have something other than the AstraZeneca vaccine. So I think that judgment was quite right. The judgments are made about the use of vaccines all the time in terms of their benefits and the risks, which is why you only get some vaccines at certain ages. For example, the vaccine against pneumococcal pneumonia, so on, an age-related vaccine. Again, with the flu vaccine, age-related. So those judgments that are made about the costs in terms of the risk undertaken, plus the benefits as against the benefits from having the vaccine, are worked out all the time by the JCVI in order to give us a vaccine program that works, to give us maximum benefit from the vaccines with minimal adverse effects.
Thank you very much, Gabriel. Does anybody else want to comment? Professor Stephen Reischer.
Can I make a point which David Spiegelhalter made yesterday? And I think it's a very important point indeed, because, I mean, first of all, it's important to distinguish between, if you like, absolute risks and relative risks. The absolute risk of AstraZeneca is incredibly low for everybody, for every age group. The relative risk is slightly different to the individual. But as David Spiegelhalter pointed out, in many cases, we're doing things in this pandemic, not just for ourselves as individuals, but for our communities, so we don't spread the infection. And when you factor that in, and that has been central to why we've been so effective in dealing with this pandemic, people have stayed indoors, young people have stayed indoors, not so much for their own good, but for the good of their communities. If you factor that in, then for everybody, it makes sense to take the vaccine. Now, the point is, and I think one of the things that we've discovered over the last few days is just how seriously safety is being taken. If anything, it shows us that safety is hugely emphasized. What we're saying is, even though it's a tiny risk, if there's an alternative vaccine, it makes sense to take the alternative vaccine. So it's a sensible thing to do, but let's not hype this. The risk to anybody is astronomically low. And what we've seen is safety is so important that we're being very, very cautious indeed. So really, there isn't much need to worry. And again, let's take the vaccines, not only for ourselves, but for our communities, so that everybody is safe and we can all come out of the pandemic.
Thank you very much, Stephen. Moving on to the next question there, it comes from Alexandra Thompson from Yahoo. Alexandra.
Hello, everybody. Good afternoon. The Transport Secretary has said that we can start thinking about summer holidays. I'd be interested to hear your take on that. Do you think that that's reasonable considering the vaccine programme success, or is it premature in your opinion? Thank you.
Thank you very much. Christina touched on this in her presentation. I wonder if I could come straight back to you, Christina, on that.
Well, I mean, to be honest, I don't think we should be having any international travel this summer. I think, we've got ourselves finally into a reasonably good position. We've got an effective vaccination campaign. The biggest threat to that is new variants, without doubt. And, we can see the world is surging, particularly countries that are really populous like Brazil and India, the US, all have very high case rates. And so it just, to me, it makes sense to try and stay safe until the autumn and go into autumn in a really good position. So I think it's a bit of an ill-advised move, to be honest.
Thank you very much, Christina. Does anybody else want to comment? Does anybody think that it's a sensible thing to be doing? Gabriel, did you have your hand up?
Not for it being a sensible thing to do at all, Alice. It isn't. It's absolutely the wrong thing to do. People should indeed, of course, have holidays. We all deserve a holiday. I think there are two really good reasons why it shouldn't be abroad. One is, of course, that there are variants loose. And although our vaccination program is going well, we know against some of the variants, the virus can dodge to a certain extent the immunity provided by the vaccine. And we also know that some people can't have the vaccine. So for whatever reason, health reasons, or maybe because some of their communities are not accepting the virus or the vaccine or getting the vaccine in exactly the way that Christina said. So I think there are a whole load of reasons we don't want to get the virus down and import new variants, which will cause us more difficulties. That's the essential reason. The second reason is there's plenty of domestic tourist industry to be supported in Britain and in Ireland. And there won't be a huge tourist trade coming to Britain and Ireland. So I think there's a sort of duty on us all as well to try and support local industries.
Thank you very much, Gabriel. Dr. Zubaida Haque.
You have to wonder, what is the purpose of having a traffic light system and expensive COVID tests if we have a completely porous border? And we do. We have a border that's like a ship at the moment. The most astonishing thing is right now, and Prime Minister himself spoke about this last Monday, and even before that. Right now, we have a third wave on our doorstep in Europe. And yet, and this is extraordinary, none of those countries are on the red list of banned countries. So people can come and go as they please, while the government puts the odd country like Pakistan and Bangladesh on their red list, but ignores all the countries on our doorstep. And we know countries like France have relatively high cases compared to other countries of the South African variant. And we know that the South African variant can resist some of the vaccines. So it is extraordinary. There's absolutely no point having that kind of system. The second thing is you have to wonder, what is the point of having an expensive COVID system? Who is it for? It's clearly just for a handful of people rather than for everybody. And as my colleague Gabriel pointed out, it won't necessarily stop new variants coming in. So we do have an extraordinary policy at the moment that's not going to protect us, that's going to be expensive, and that won't stop people from mixing when they're abroad with people from all over the world.
Thank you, Zubaida. Professor Martin McKee, you wanted to come in on this too.
Picking up directly on what Zubaida has just said, I think one of the difficulties is that the categorization of countries into the different traffic lights will be based on the level of vaccination and infection in the population living in those countries. But of course, people coming from here going to resorts will not only be mixing with people from those countries, but they'll be mixing with people who have come from many other countries to the same resorts. And so therefore we would need to have information on the background rates of vaccination and infection and so on in the countries that they have come from as well. In the same way that people moving around through airports will be mixing not just with people going from the UK to Spain, for example, but there will be people who will be transiting through, for example, in Madrid or Barcelona, people coming from South America potentially, or wherever else. So I think that this tends to oversimplify the nature of international travel. And for that reason, I think it's significantly problematic.
Thank you very much, Martin. Stephen, you'd like to comment too?
Just briefly, I wish this government would learn from experience. I mean, we got levels down incredibly low in this country last summer, but international travel receded things. And if there was a one-word answer to Grant Shapps, it would be Chile. Chile, at the beginning of the South American summer, allowed people to travel internationally. Chile has actually got more vaccinations than this country. People went abroad. They relaxed restrictions domestically. People came back from places like Brazil with infections, and the infection rate surged. And although they were doing incredibly well, they've had to impose a really strenuous lockdown. I was talking to one of my students the other day who's in Chile and was in Santiago, and so severe was the lockdown they couldn't even go out to get food. We don't want to be back in that position. And if we really mean it when we say it, that the end of lockdown must be irreversible, it's not good enough to talk about it. We've got to learn from experience. We've got to impose the necessary policies. And above all, we've got not to re-import infections when we're putting so much effort into pushing them down at home. So as I say to Grant Shapps, remember Chile.
Thank you very much. Well, I think that was a fairly comprehensive answer to that question. Thank you, Alexandra. We're going to move on now to some questions from the public. And the first person to ask a question is going to be Lorraine Prince. Lorraine, are you here with us?
Hello, I'm here. Ooh, sorry.
Hi, what's your question?
Hello, I identify as a Black British woman who is a teacher and who has several allergies and is diabetic. I've taken my first vaccination of the Oxford AZ, and I'm feeling slightly nervous to take the second, but I will be taking it. I have a few questions. Can you please explain why many of us were told not to take the Pfizer vaccination because of allergic reactions, but are advised to take the Oxford AZ, which has been shown to have links to blood clots? And do you think that should be readdressed? That's my first question. The second, what are the signs or indicators of people who are experiencing blood clots or low blood platelets? And the third question is, how can I as a Black woman convey my concerns to my GP and they are taken seriously, as many reports and studies show that this has not been the case for Black or ethnic minority women? Thank you.
Thank you very much, Lorraine. Who'd like to start with Lorraine's question? A couple of questions in there. One about the difference between Pfizer and AstraZeneca vaccines and the risks associated with them, the very tiny risks. Professor Dean Pillay.
Hi, Lorraine. Thank you very much for your questions. I'll just start with, first of all, congratulations with getting your vaccine, and congratulations for making your decision to have your second vaccine. I think we would all agree that that's the right thing to do, despite obviously their concerns. The issue about that you mentioned with regard to various risks of vaccines, I think one of the clearly there's new data being made available all the time in terms of as more vaccines are used, particularly for rare events. And so it is not surprising that the guidance does change over time. The other thing is, of course, the original clinical trials that are done, which inform the licensing and approval of the vaccines, which then allow the NHS to give it out. Those trials identify different sorts of potential contraindications or reasons to be careful. But those trials are very, very small in the context of the huge amount, the biggest size of the rollout now. So it's not surprising that these things will change. And so that's the reason why the guidance that's been given to GPs and so on is being updated all the time. And I wouldn't read too much into that, and I wouldn't read too much into differences between the vaccines. From my perspective, they're pretty much interchangeable with regard to whether one is used or the other. And I think the priority should remain that whatever vaccines are available, which of course is a function of the supply chain and all the rest of it, they should be used, and we should be encouraging people to take them up, taking account of the government's position on for under 30s and so forth. So that would be my comment around around that set of questions that you've given. But others, I'm sure, will want to contribute to some of your other questions.
Zubaida.
I'm sorry, I can't answer your medical questions, but Lorraine, you've raised a really interesting issue about the relationship between Black and ethnic minority people, and particularly Black people, and health services and health providers and health professionals. We know it's a huge issue. The data is overwhelmingly there when we look at how Black women are 5 times more likely to die in childbirth, even before the pandemic. We heard that even during the pandemic, Black pregnant women were much more likely to be admitted into hospitals more than any other group. We know, of course, also from Black nurses, Black and ethnic minority nurses, when they came forward about PPE, that they were less likely to be listened to. So it is a real issue about being listened to, about being heard, about your voices, our voices being heard. And we know, of course, that issue is also related to issues of distrust and why Black and ethnic minority groups have higher rates of vaccine hesitancy. Although the good news is the good news is that uptake with vaccines among Black and ethnic minority groups is getting higher. And that's because health services, health professionals and health providers have worked hard. And that is the answer, where the onus is not on you to be believed and to be heard. The onus is on the NHS and health services and health providers to hear you, to seek out better ways of hearing you, of providing services, of getting the vaccine to you, and hearing about concerns and anxieties. And I think we, as Independent Sage, we will work on that. But as a country, we really need to put the emphasis and onus on the NHS and health services. So good luck. And it's fantastic news that you've got the vaccine.
Thank you very much, Zubaida. I mean, that whole, I think the underlying thread there, Lorraine, in your question, which is about having concerns taken seriously. I mean, that is part of the relationship between people and their doctors, isn't it? It's absolutely crucial that trust is there, and that people feel that they can ask those questions and that they will be taken seriously. Gabriel, did you want to comment on this question as well, on Lorraine's question? Or you're on mute at the moment. Maybe that.
Yes, just quickly to say that Lorraine, a great question with several interesting bits. The difference in the contraindications is marginal between the Pfizer and the AstraZeneca. They both say that people who have hypersensitivity to any of the established hypersensitivity to any of the ingredients shouldn't have them. The difference is with the Pfizer, in the very early stages, of course, there were a couple of people who had a very serious anaphylactic reaction immediately. That hasn't been seen with the AstraZeneca. So I think that's the main difference. And if it is any consolation, of the 79 cases that were talked about the other day in the briefing that have occurred in the UK that the MHRA has been looking at, all of those case reports came from the first dose. None were from second doses. So as far as we know at the moment, there is not a problem with the second dose. So I think your decision's an entirely rational one.
Thank you very much, Gabriel. Martin, you wanted to come in as well.
Yeah, you had a question about what symptoms to look out for. It's actually on the government's website, and I could put a link in the chat if it would help. But essentially, a new severe headache. Sorry, I should say these symptoms are ones which arise between from around 4 days to 4 weeks after the vaccination. A new severe headache, not helped by the usual painkillers or getting worse. A headache which seems worse when lying down or bending over, an unusual headache accompanied by blurred vision, nausea and vomiting, difficulty with speech, weakness, drowsiness or seizures, a new unexplained pinprick bruising or bleeding, shortness of breath, chest pain, leg swelling or persistent abdominal pain. But all of these are on the website, and it's important that people are aware of them.
Thank you very much, Martin. Lorraine, thank you very much for your question. We're moving on to the next questioner now, and it is Isaac Levy. Isaac, are you there?
Yes, hi everyone. Sorry I don't have a webcam. So my first question, so from my understanding, the vaccine doesn't stop all cases, it just reduces serious cases. That's the main point of it. And therefore, because you can still catch COVID even after the vaccination, what is the point of a vaccination passport? If you've had the vaccine and you enter a pub, for example, why would it matter that you're surrounded by people that haven't had the vaccine? Surely you shouldn't have anything to worry about as you're the individual who's protected. If anything, it should be the person who isn't vaccinated who should be worried, no? And my second question, I'm not an anti-vaxxer, by the way, I'm just very, very cautious. So how come the government are pushing the vaccine on young and healthy people? In the beginning, it was only the elderly and vulnerable, but they kind of keep moving the goalposts. If someone could provide me with a simple explanation of why they insist on vaccinating all adults when the elderly and vulnerable have been vaccinated. And if the answer is because there are no studies on the long-term side effects of getting COVID at a young age, couldn't I come back with a vaccine usually takes an average of 10 years to develop? We don't know the long-term side effects of me taking a vaccine, seeing as someone my age of 23 has over a 99.9% chance of surviving COVID. Why should I take that risk? Thank you.
Thank you very much, Isaac. So 2 questions, I think, if not more. One about vaccine passports and whether they're particularly useful, and one about whether young people really should be taking the vaccine. Who would like to start with one of those questions? Susan, Professor Susan Mickey.
Thank you for that, or those questions. On the question of young people taking the vaccination, 2 reasons spring to my mind. I'm sure others can come in with others. But the first is that, as we saw actually from Christina's presentation, younger people are increasingly getting COVID, and young people can get long COVID, and quite a percentage of people, young people who even get quite minor symptoms at the beginning, go on to have really unpleasant symptoms that can be debilitating in terms of their working and their social, their family lives for many months. So the idea that this is an old person's disease is really changing. So the first is to protect yourself. The second is that there's evidence accumulating that vaccines not only help to protect the person, but also reduce infectiousness. It's not clear by how much, others may know more than I do on that question, but it definitely looks like it's decreasing infectiousness. And given that 40% of people who have COVID and therefore infectious are asymptomatic, that's really important, because you won't know whether you're going around spreading the disease if you're not symptomatic. In terms of the COVID passports, there's a whole range of problems here, but I'll just take two. One is we've heard about the big differences in terms of take-up of vaccination and also some of the reasons for it, which is historical and structural inequalities and discriminating experiences. And so it's not a level playing field. And what it means, if we're talking about passports for, or they're called vaccine certificates sometimes, for going in and out of different venues like hospitality or sporting venues, it means that those people in society who are already disadvantaged are being further disadvantaged by being excluded. And we really don't want a society where we've got a divide between those who are, yes, you're all right, you can come and enjoy all the things that we all want to enjoy in terms of community life, and a group who can't. And the second reason is that it takes the spotlight away from the focus on making places safe. That's what we want. That's what we want the government to really put the resources in, to ensure that whether it's workplaces or schools, pubs, restaurants, sporting venues, all of those places are safe for everyone. And one of the key things there is to ensure good ventilation, because there's more and more evidence that the transmission is primarily through aerosol transmission, these tiny droplets that can stay in enclosed indoor spaces for many hours. And so one person can end up infecting a lot of people. And I would like us to go to a system, rather like we have for cafes and restaurants, of publicly displayed hygiene ratings on the wall, that we have publicly displayed ventilation ratings. So we have an idea, if we go to a pub, is that a well-ventilated pub where our risk is pretty low, or is it a poorly ventilated pub? So that's the other problem about the passports. It puts the onus onto the individual rather than making spaces safe for everyone.
Thank you very much, Susan. And Zubaida.
I mean, Susan mentioned some of the really important issues with vaccine passports, but there are so many other issues. First of all, it's false security, simply because vaccine passports don't really do what they claim to do. They can't really guarantee public health safety, because while the vaccines are very important and they will suppress severe disease and so on, we don't know to what extent that they will stop transmission. We don't know how long they will last. There are so many issues that we still don't know about the vaccine. And that means that they can't promise that saying that you've been vaccinated isn't a guarantee that everybody is safe. Second issue with vaccine passports is the question of how long are we going to use them? Are these going to be something that's permanent? Because quite frankly, if the government is doing nothing in the background in terms of keeping cases down, in terms of robust test, trace, support and isolate, in terms of stronger border restrictions, in terms of, as my colleague Susan rightly pointed out, ensuring that workplaces and schools are safe environments, then we will simply have viruses circulating all the time. And for long as we have the virus circulating, as so long as the under 50s have not been vaccinated, or a large part of the population haven't been vaccinated, it means that vaccine passports are more likely to become permanent than not.
Thank you very much for those responses. Thank you for your question, Isaac. I'm going to move on to the next question now. And can I please ask questioners to keep their questions singular? So you're not allowed to ask more than one question. The next question comes from Sue Watson. Sue, are you with us?
Yes, hi. So I'm going to keep it, I was asked to keep it to 2 questions, but I'll cut down to 1.
Thank you.
I'm very interested in some of the responses around the vaccine passports. So my question is from an ethical perspective. What are the panel's views, really, the ethics of having COVID passports or not, particularly as potentially this would be some other private company that would be holding our personal data? Thank you.
Thank you very much, Sue. We've touched on this already. Who would like to elaborate? Professor Anthony Costello.
The whole question of vaccine passports is quite complicated. Expressing a personal view, there is a case for people who are working in hospitals and care homes to have a proof of vaccination before they can deal with patients in future. Now, I'm sure there'll be different opinions of that on this panel, but there is a precedent for it in that if you're a surgeon, you must have evidence that you do not have hepatitis B and that you've been vaccinated before you're allowed to operate. And so that may be one. The question on whether you do long haul or flights generally, I suspect will end up with a passport. We could debate the ethics of that. And the third, which might have been more relevant to Isaac, is my guess is, whether we agree with it or not, that getting back to stadia, football matches, rugby matches, theatre may actually involve a passport, because the present government is so keen to get that sector of the economy going again. But you're right, it does raise ethical issues over whether that is right and who owns the data. The big problem, of course, is that in society right now, all our data is hoovered up completely and utterly and algorithmized by Facebook, Google, and all the big data companies. This is, okay, a health issue, but I imagine that there would have to be checks and balances on anonymizing data and the like. But I think there's tremendous issues around fraud and how you can identify people in order to show that they've got vaccine status and the like. So you're right to raise this question, Sue.
Thank you very much, Anthony. And Dr. Tallulah Oni, if you'd like to comment too.
Yes, I think that's such an important question. I'd like to add another dimension when we think about the ethics, which is the equity dimension, right? And relatedly, the opportunity cost. I think it's important when we have the discussions to also think about the timing of the intervention. And the reason I say that is because if we think about it both domestically and internationally, right? So domestically, what is the opportunity cost of losing momentum on focusing on increasing access and uptake of the vaccine? Because having a certification when you have significant proportions of the population that are not yet vaccinated or still have questions that need to be addressed could potentially widen inequality. So it'd be really important for us to focus on saying, how do we actually ensure that we increase uptake? And then if we look at internationally, whilst there is some argument down the line for having certification for travel, there is again that opportunity cost and timing, recognizing where we are now, where the majority of countries globally are nowhere near where they should be in terms of vaccine access. What that's going to end up doing is widening inequality in terms of travel and access if we're putting that into place now. So what we should be talking about is, how do we ensure both locally and globally everyone has access to the vaccine? If we're in a position where suddenly everybody is vaccinated that can be, it becomes a very different conversation. But I think the critical issue now is one of equity.
Thank you, Tallulah. And Stephen, you'd like to answer?
I mean, one of the things that's plainly obvious from the discussion we've had so far is that vaccine passports cover so many different things that it leads to a completely confused debate. So, for instance, there's the issue of what they apply to. Do they apply to, if you like, things that are seen as privileges that we don't do all the time, like going on holiday, or are they applied to everyday activities? Do they apply to everybody or to specific jobs, like healthcare workers? Do they apply now, or when everybody's got the opportunity to be vaccinated? So there are so many different things. The government has flown so many kites around this, they've all become tangled together, and the confusion reigns. But I think there's one very simple point to be made. vaccine passports are a sign of failure. Because if everybody was vaccinated, you wouldn't need passports. So the question is, how do we get everybody vaccinated? And what's the impact of passports on take-up? Now, it's particularly relevant to those communities who have doubts and who are hesitant. And the problem is that once vaccine passports are used for things which are essential to everyday life, going to the shop, going to the pub, socially participating, then in effect they become compulsory. They become something done to you, imposed on you, not something done for you. And that feeds into precisely the doubts of those minority communities who have historical experience of health interventions sold to them as being good for them, actually being imposed upon them. Particularly examples like the Tuskegee syphilis experiment, which was done to Black people, or polio vaccinations in Nigeria. There is long historical experience. People have doubts. And the problem is, once vaccine passports seem compulsory, they feed precisely into the doubts which put hesitant communities off getting vaccinated. They are counterproductive, and they get in the way of the good engagement initiatives that we need. So the bottom line for me is that actually vaccine passports compound the failure, which ironically makes them necessary. And we should be stopping talking about vaccine passports, because even talking about them is alienating people. Stop alienating people, engage with people more, and that's the solution. Community engagement, not vaccine passports.
Brilliant. Thanks, Stephen. Thank you, Sue, for your question. We're going to stop talking about vaccine passports now, I hope. We're moving on now to Ed Watts. Ed, are you with us? And what's your question?
Indeed. Thanks everybody for your hard work. It's very much appreciated. My question's about vaccines, variants and long COVID. So while we know that vaccines give us some protection against severe outcomes from variants, depending on the vaccine, is there any evidence that you could or couldn't develop long COVID having been half or fully vaccinated? And if there is no evidence, what's your best guess?
Oh, that's a tricky one, Ed, isn't it? Who's going to start with this very tricky question? Professor Deenan Pillay.
Thanks, Ed. I mean, that is a really complicated question, and I'm not going to provide an answer, because I think it would be too premature. But I think there is a danger in conflating a few concepts that's encapsulated within your question. The nature of long COVID is not necessarily a sort of long, mild, short, COVID as a COVID in terms of an acute episode. It's unclear what that longevity is due to, the reasons for that, and it may be that those reasons are quite different to the reasons you can get severe a COVID following an infection, be hospitalized. And what follows from that, it's therefore, I think, premature to be thinking about it as an escape from the vaccines, or because you've been only partially vaccinated, that some sort of longer COVID will develop. I think we're talking about very different things here, as I say. So whilst of course there is now clear evidence that there is that a substantial number of people get long-term symptoms after COVID, that may be due to a range of different mechanisms, biological mechanisms, and the degree to which I think vaccines play a role in modifying that is unclear. Other than to say, I think the what is likely, although we wait and see over time, what is very likely is if in response to a vaccine, one does not get infected, one's protected from infection, what does follow is that it's very unlikely then some long-term consequence of that infection will follow, because you've been protected from a vaccine. I think that's the principle so far, but I know that's not an answer to your question, but nevertheless, trying to tease out some of those strands within a really interesting question.
I wonder actually if the ONS is tracking and sharing this data in the same way that it tracks and shares data on positivity cases and deaths. Is there any tracking of long COVID to see how the vaccination program might be affecting that? Do we know? That seems to be a question that nobody's prepared to. Oh, go on then, Martin.
Well, I don't know. No, I don't know the answer to that question, but I think, remember, within long COVID, there's a whole spectrum of mechanisms, as Dina has said, and some of them, for example, are as a consequence of the severe effects of the virus, for example, on the lung, leaving people with damage to the lung or the heart or the blood clotting. And clearly, because the vaccines are very effective at preventing severe disease, at least for those elements, we can be pretty sure, in addition to their effect on reducing the risk of infection, that the vaccination will reduce the incidence of those elements of it. But I think for the other, you said, what is our best guess? My best guess is that it will have a very beneficial effect, but it is only a best guess at the minute, at least for the bits of the mechanisms that we understand less.
Thank you very much, Martin. And Professor Cole-Friston, you'd like to say a word here?
Yeah, so if we assume that Dinan's and Martin's best guesses are true, then you can sort of read that as saying that if vaccines convey sterilizing immunity, you just can't get the infection if you're vaccinated, then in principle they should preclude any complications, including long COVID. So then the question reduces, what's the probability of sterilizing immunity following vaccination? And the best guess formally in terms of the quantitative modeling, I can give a figure, but I hesitate to do that. But what I will say is, if you actually try and estimate it from the ONS data, that doesn't include long COVID, but certainly has lots of other aspects to it, would give you a good handle on the efficacy of conveying effective or sterilizing immunity. It has substantially increased as more data has become available. So we started off with estimates in the range of, say, 48%. And as more data comes in, there is more and more evidence for actually quite a remarkable efficacy and effective efficacy in terms of sterilizing immunity. So if you don't want long COVID and you subscribe to Dinan's and Martin's best guess, then you should get vaccinated.
Thank you very much, Carl, and thank you for that question. Ed, our next questioner is Jennifer Sadler. Jennifer, what's your question?
Hello?
Hello, we can hear you.
Good. Can you not see me?
We can see you as well.
Oh, good, good. Thank you for taking my question. I think actually it's more or less been answered, but I've been concerned about vaccine-resistant variants and what happens when, if and well, I'm assuming when they become widespread. Are we going to end up back at square one without a vaccine that works? How does this all end? It seems to me this could go on forever, a kind of lockstep with the virus for decades. Does it seem that way to you?
Thank you very much, Jennifer. Anthony.
Well, I'll let the others who know more about this answer. But I mean, look, we have this constant battle with the influenza virus, don't we? By adjusting the vaccine each year. And you're absolutely right to be concerned about variants. In fact, there's a paper just come out in the last day or two, not peer-reviewed, but quite a detailed paper from Brazil showing a whole number of variants where they're raising the issues of whether you're going to get vaccine escape. And also people are concerned that in America, there may be a lot of variants and that they're not doing sufficient genomic surveillance there to pick them all up. And in many parts of the world, that will be the case. So yeah, I think best guess is at some stage we will get variants which will require new vaccines to be made and booster doses to be given. But, I have a different flu vaccine every year. The new RNA technology suggests that from designing a vaccine to producing it, approving it, and rolling it out with a new strain of the vaccine, if you like, is less than 6 months. So that should be within the capability, although there will be an expense attached to that. So I think we can fight off variants, but my guess is they will emerge. But Dinan is more of an expert on this, and Gabriel.
Dinan, would you like to comment?
I just agree with Anthony. He's now a better virologist than me, and so can speak very eloquently.
Thank you very much, Dean.
The only comment before Gabriel comes in is, if we want to look at the worst case scenario, we need to look at Brazil at the moment, as Anthony raised Brazil, which is that, you know, not only has there been a large pandemic there, but with very little control, a very little political will to control. And what we're seeing is the emergence of variants because there's just uncontrolled spread. And so in this regard, as we've said before, vaccines rollout must go along with a continual, very, very heightened awareness of how to limit transmission. And I think getting back to normality is something that's going to be a long way away, and rather we've got to be getting used to safe places to work, how best to limit spread through other mechanisms, and awareness of general and a strong public health structure in order to limit our own transmission and therefore generation of variants in the future.
Thank you very much, Dean, and Gabriel, I think you wanted to comment as well.
Yes, it's a very good question. The reason why we're getting so many variants is because there's so much virus around. The more virus there is in the world and the more it's spreading and replicating, the more mutation will take place and the more dangerous variants we're liable to come up with. That's a general rule. So therefore, that's one of the reasons why we need to be internationalist about this, and we need to try and ensure that COVAX, the WHO vaccine program, gets as much resources as it possibly can, and that we put out vaccines across the world as quickly as we can to play a part of what Anthony correctly said about the Dean, the control programs across the world are of enormous interest to us because they will keep us safe. We can keep ourselves safe by our own efforts, but we also need other countries in the world to be on the same page and operating together, and particularly the poorer countries to be given the resources, because that is so in our interest. And it doesn't seem to me to be on the government's agenda, particularly at the moment, but perhaps it needs to move up their agenda. The whole issue of continuing international aid in this COVID pandemic.
Thank you very much, Gabriel. Thank you, Jennifer, for your question. Our final question comes from Karen Garner. Karen.
Hello. I don't
Hi.
think I can put my video on. It's been disabled.
Oh, we can hear you though, so go ahead.
Okay, no worries. So yeah, back to, I know we've said, oh, I'm now starting, there I am. I know we've said quite a lot about blood clots already, but what I'm not sure about is whether there's been any specific information about who is most at risk. I can see from the information that it's 2/3 women, which makes me nervous about getting my second AstraZeneca dose. I've had the first one. It was about 4 weeks ago, so I feel like I can say, okay, well, I'm all right. But it is 2/3 of women. Do we know why that is at this point? Do we know if there are any specific risk factors or indicators in people getting blood clots? And is there a different risk between first and second dose? Thank you.
Thank you very much, Karen. Dean.
Karen, there'll be others that will want to add, but I just wanted to say something about the female-male split. And it was made clear in the press conference describing the 70-odd cases that there have been of this specific clot in the UK. The reason given why there are more women than men having clots is that more women have had the vaccine than men, and that there is actually, when you take that into account, there is no extra, there's no signal that suggests that women are significantly more likely to get this than men. So please be reassured on that issue. And clearly this is a very specific syndrome, a very specific. It's not just clots. There are many reasons for getting clots. It's a very specific syndrome. And from my understanding, there's not yet a biological understanding of the specific risk factors. And clearly that would be enormously useful, because it would, could be used to then stratify, who would get the vaccine or not, or be able to describe who's at higher risk. But I'm not aware of anything around that yet.
Thank you very much, Dean. And does anybody else want to comment on the risk of clots? It's quite reassuring to know that it's not heavily weighted for women compared with men in some ways. Yes, Martin.
Yeah, but just to reinforce what Dean said, I think a lot of what we're seeing is, first of all, the numbers are still very small, so it's very difficult to say anything definitively about differences by age or by gender or particular risk factors. But also a lot of what we're seeing is that in different countries, some groups have been tending to get the AstraZeneca vaccine, particularly younger people in the health workforce who tend to be predominantly female, and in particular in those countries where the AstraZeneca vaccine was not being given to older people at a particular time. So I think we basically don't know at the minute. And the mechanism that seems to be involved is one where it's not obvious why there would be any gender differences or any of these other things. It's very similar to a phenomenon that is sometimes in very rare cases observed with heparin, which is a blood thinning agent. And given all of that, it's likely that what we're seeing is a bit of an artifact of who has got the vaccine, this AstraZeneca vaccine, compared to who has got one of the other ones.
Thank you very much, Martin. Thank you, Karen, for your question. I'm going to have to draw things to a close. Thank you. I'm going to have to draw things to a close now, but as is our tradition, before we finish, I'd like to ask Sir David King for a few words. Sir David.
Thank you, Alice. I think we all know that vaccination has been a remarkable success in Britain. What the figure that struck me from Christina's presentation today was over 55s, now over 94% of all people over the age of 55 have been vaccinated. Over 50s, 87%. This is, sorry, that's the 50 to 55 age group. This is a remarkable success. And once again, let me congratulate the National Health Service, our public services, for rolling this out so effectively. Of course, we remain with problems with deprived and ethnic communities. There is an improvement, as we've heard, but we must see that there's much more work done in that area. Now, none of my colleagues will be surprised at my final comment. Find, test, trace, and isolate with support is the way to bring this pandemic to an end. What I'm now calling for is government ministers, the Prime Minister, the advisors, to all bring up the issue of trace and isolate and support. Do we believe that what has happened so successfully in some other countries in the world with operating that system, do we believe that in Britain that cannot work? I don't believe that there's a real understanding of the purpose of testing. Surely the major purpose of testing is not to get statistics. Surely the major purpose of testing is to see that those who test positive are able to isolate. That means we have to see that the proper level of support is there and that they can isolate away from vulnerable people. So I think, once again, we see a failure here from the advisory system as well as the government, I'm suggesting, and I'm challenging the advisors now to step out and explain, where do they stand on this? My colleagues, once again, have, I think, done a wonderful job, and I just want to thank them for all the work they're doing. Thank you.
Thank you very much, Sir David, and thank you to the whole committee whose work continues to inform the public about the risks posed by the coronavirus crisis. Independent SAGE, as well as these Friday briefings, produces reports with expert analysis and advice covering all sorts of different aspects of the pandemic. And all of those can be found on our website. Thank you very much for your questions today. Thank you for watching, whether you're watching us live or catching up. Do follow Independent Sage on Twitter and Instagram if you don't already. We'll be back same time, same place next week. Stay safe, keep well. Goodbye, everybody.
Bye.
Bye, everybody.
Bye.
Thank you. Bye.